This is TTT Live. I'm Stacey Ann Providence. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago, and we're bringing you live coverage on TTT, Talk City 91.1 FM, Sweet 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online. We go now to the Minister of Communications, Donna Cox.
Good morning and welcome to today's virtual media conference to apprise you of government's efforts to combat COVID-19. Today with me are the Minister of Health, the Honorable Terence Dial Singh, the Chief Medical Officer, Dr. Roshan Paraswaram, and Dr. Anthony Parkinson, the Technical Advisor, Hospital Services in the Office of the Chief Medical Officer at the Ministry of Health. The Minister of Health, the Honorable Terence Dial Singh, will provide an update on COVID-19 in Trinidad and Tobago.
Thank you very much, Minister Cox. To the Chief Medical Officer, to my left, good morning. To Dr. Anthony Parkinson, good morning. Ladies and gentlemen of the media, and most importantly, citizens of Trinidad and Tobago. My update this morning is not going to be the usual update. It is going to be unusual because we are now in unusual times. Let me state clearly up front that the world has changed more in the past 4 months than in the past 400 years. We have changed more in the past 4 months than we have possibly changed in the past 400 years. Societies are grappling with a global pandemic of epic proportions. At the very start of this pandemic response, the Honorable Prime Minister gave the country a very simple yet profound strategic message. And that is the objective of the Honorable Prime Minister and the government was a simple 2-word objective: save lives. 2 words, powerful words. We want to save lives. To achieve that objective, every single measure that we have taken at the Ministry of Health, with the support of the Minister of National Security, my colleague, Minister Stuart Young, reporting to the Prime Minister, with the legislative aid of the Honorable Attorney General, has been a simple message: stay home. So the entire strategy can be encapsulated in 4 words: save lives, and an effort to do that: stay home. These are not usual times. We have won nothing. The virus is lurking amongst us, probing our defenses, and at the first sight of weakness in our defenses, the virus will strike again. And you know what? We will have to start over. My concern was heightened in looking at the news last night and reading the newspapers this morning. Cops intercept 5,525 vehicles. One person said, "I'm going to sell a dog." Another said, "I'm just going to meet my boyfriend." That is not essential. Selling a dog and meeting your boyfriend at this point in time is not essential. This is contrary to saving lives and staying home. Another newspaper, COVID jam. 9,825 people caught in roadblocks. Most flouted stay-home rules. Outings to meet boyfriends and to breeze out. Ladies and gentlemen, if we have to breeze out home. Let us save lives by staying home. But the third headline in an article inside a paper was the scariest of them all. That headline said, "Non-essentials slackness leads to roadblock. Day of COVID-19 policing." But inside of that newspaper is the most shocking example of wanton carelessness on the part of a private school, where it says on page 15 of that newspaper, private school set to reopen. Ladies and gentlemen, it is clear that some sectors of society are still not getting the message. We are concerned. We have crossed one hill. If we do not adhere to the simple message of saving lives and staying home, we will have to start over this whole cycle again. Is that what the citizens of Trinidad and Tobago want? Countries which were held up as the gold standard previously of how to deal with COVID-19, and I call no country in particular, we just learn. Countries which were held up as the gold standard have now regressed. They have gone back to ground zero with new infections. We must learn from the errors of others. We have won nothing. Do not misinterpret the data to mean that we are in the clear. When you look at international media, supplies for healthcare professionals are scarce. They are running out. In some countries, doctors and nurses are now using garbage bags as gowns. We are not there yet. In some countries, nurses and doctors are reusing N95 masks. We are not there yet. But I promise you, we will get there very soon if what transpired yesterday continues. At this point, I would like to heartily congratulate the Commissioner of Police, Gary Griffith, and his men for coming out yesterday and sending a very clear signal to Trinidad and Tobago. This is not business as usual. Let me repeat. The world has changed more in the past 4 months than possibly the past 400 years. You would have heard the Honorable Prime Minister express publicly his concern that his daughter is in ground zero in New York. You would have heard him say that he had to attend the funeral of his favorite brother with 5 people. In many countries, funeral masses are now taking place in a convoy setting with 5 minutes, and hearse after hearse pass and the priest does his blessings in 5 minutes. We have changed. On a personal level, I as a parent have the same anxiety for healthcare workers. I have 2 children, 2 in-laws, so I have 4 children. 3 of them are doctors, 3 of them. And I worry for their safety because they are going to be placed in jeopardy, not by genuinely ill people, but by people who continue to flout the regulations to stay home. We are all worried. If we continue with that type of behavior, which plays out in the headlines of these 3 daily newspapers, I fear for what will happen to the healthcare system. So far, so good. Our parallel healthcare system has stood up to the first hill test. But if we continue to flout the measures to stay home, the second hill test may not be so successful, and we will roll back. We will regress. So that is my simple message this morning as we use this forum to address squarely that if we do not heed the message of the Honorable Prime Minister in 2 words, save lives, and then the operationalization of that, which is to stay home, Trinidad and Tobago will be in a very bad place. In closing, I urge all citizens, regardless of political affiliation, socio-economic standing, race, color, creed, stay home, and we will get through this together. Thank you very much, Minister Cox.
Thank you very much, Minister Diyal Singh. The Chief Medical Officer, Dr. Roshan Parasram, will now provide us with a clinical update.
Good morning, Honorable Ministers, members of the viewing and listening public. So as of today, the clinical update is as follows. 1,320 tests submitted so far. 114 patients have been confirmed positive. Of these, there were 8 deaths recorded. There are 21 discharges. 1 occurred yesterday from the Cora facility. Additionally, there are 60 persons who remain hospitalized at either Cuva or Cora. There are 10 persons at the Cora institution which are in very stable condition. There are 59 persons who are ambulatory at the Cuva facility and 1 person in the HDU at Cuva. I just want to bring a little update in terms of the testing, because I think there's a little information circulating that there's not clarity in regards to testing and the way we test in the country. So let us start at the beginning. So a patient presents to a health facility with signs and symptoms that meet the clinical case definition as defined by CAF at the beginning of the epidemic and continues to change as the epidemic progresses. So they meet the case definition. A swab called a nasopharyngeal swab, which is basically looks like a Q-tip, is actually taken from the patient's nasopharynx. It's transported to the lab, which is the Trinidad Public Health Lab. Once it gets there, it goes onward to the Caribbean Public Health Agency, which is the regional reference lab for testing for COVID-19, and still the only lab in Trinidad and Tobago that actually does the testing. They would decide, based on their clinical case definition, if a sample is rejected or not. If it is not rejected, it goes onwards for testing, and that process actually continues by a process called the polymerase chain reaction, which is a PCR machine, which is the gold standard, and I believe CAFA had said it is highly sensitive and specific with regards to testing for COVID, meaning that a true positive is very likely and a true negative is very likely. So that is basically the process. I have engaged the Caribbean Public Health Agency as well as my Trinidad Public Health Lab to produce a video which will be coming out hopefully in short order to address the process in detail as to what happens from the time a patient is sampled to the time it actually is tested. CAFA has indicated to me that they're actually putting timelines, how long it takes for each part of the process in the video. So that will be shared with the population hopefully as soon as that process is complete in the next few days or in about a week or so. In terms of Trinidad's testing capacity, we are, as we said before, putting things in place to begin testing in Trinidad for Trinidad and Tobago. And that process is moving along swiftly with the training of persons and is scheduled to be completed hopefully in about a week's time. We already have the kits and equipment required. We already have begun the training of staff. We're in the process of having the validation exercise completed with CAFA. So in about a week's time, we will complete that process. So by way of testing in a nutshell, that is where we're at. As we spoke to the Sentinel testing, which would have begun this week, meaning sampling from one health center in every county of the country, that has begun. So it is happening in all 8 counties of Trinidad, and it has begun in Tobago as well. So I had spoken to the County Medical Officer of Health from Tobago up to yesterday to ensure that her samples are coming across, and they are. So the Caribbean Public Health Agency will give me a disaggregated report for those particular patients as separate from the other samples they are receiving. Hopefully in the next 2 days or so, we should start to see those results coming forward as well. So that is my update as for now in terms of the clinical update.
Thank you very much, Doctor. Let's hear from Dr. Anthony Parkinson, the Technical Advisor, Hospital Services in the Office of the Chief Medical Officer at the Ministry of Health, who will speak on ventilation as it relates to COVID-19. Dr. Parkinson?
Good morning. I am Dr. Anthony Parkinson. I am an anesthetist and intensivist by training. Today, my job is to try and demystify this whole thing about ventilation. It's the last aspect of treatment of COVID. It's only about 2 to 5% of patients who need this, but yet it's still a very important part, and it's a part that has been confused over the social media. Earlier, we made a short video demonstrating the use of a ventilator. Can we look at that now? So let's start. Lungs. Well, this is our model of a patient here. Don't worry about the tube in the mouth right now. Our lungs. The purpose of the lungs are to cause the body to be able to extract oxygen from the air, a gas, put it into the bloodstream, which is a liquid, and at the same time extract carbon dioxide from the liquid blood into the lungs and out in the atmosphere. That's what we call ventilation. So, what happens when the COVID hits? Most people, over 80% of them, nothing much. You get a little fever, you get a little short breath, a little bit of short breath, nothing much happens. But about 15 to 20% require a lot more oxygen, not just the oxygen in the air, but supplemental oxygen. That will involve putting on special masks, special nasal prongs to give you a little bit of extra oxygen. But there are about 2 to 5% of people who need a lot more. Oxygen is not getting into the bloodstream. Something is blocking it. What we have to do now is to support the patient on a machine. This is a ventilator, an example of the ventilators we have in the RHAs throughout the whole country. This is an example of one of them. It's a complex piece of machinery. It's going to act like this bag here. This is a bag that helps resuscitate patients who are difficult to breathe. This is a tube that goes into the patient's lungs. When we attach the bag to the tube, we are able to breathe for the patient. As I put fresh air into these lungs, the lungs expand, and the gas exchange, as we just talked about, occurs. That's great, but we can't stand here holding a bag in a patient. We have to put it on a machine. So what we do, we connect to this sophisticated piece of machinery. And this does the work of this bag. However, all this bag does is just pump air in and out. This machine now pumps air at special pressures, both on inhalation and exhalation. It does it via computer algorithm inside of the programming that makes sure we get the right quantity of the air and the right pressures. Now the function here now, as you see here, a patient who is on a ventilator most times has to be sedated. That's one. They can't be thrashing around the place. Two, sometimes we may have to paralyze these patients. Paralyze, that sounds kind of frightening. But what it means is that because you're so stiff, your muscles are acting up so much, it resists the ventilation. And that will cause a lot of problems for you, for your recovery. So that's two things. You have to be sedated, and sometimes you have to be paralyzed. Third, we have to match this machine to the patient. We do not match the patient to the machine. No, remember, we are trying to copy the function of the lungs. Besides exchanging gas, air, oxygen going in, carbon dioxide going out, it has to moisturize the air as well, condition the air, filter the air. This machine does it as well. So it's trying to replicate the lungs as much as possible. The intensivist now follows the machine, follows the interaction with the patient to see if it's successful. Success is the amount of oxygen that reaches the patient's bloodstream has to be optimal. We call it a pressure, a partial pressure of at least anything above 60 millimeters mercury. That's rather low, but it's acceptable for these patients. That is our goal. The lungs could get stiff in some instances of the COVID disease, which will cause higher pressures to be needed to be delivered by the machine to inflate the lungs, to get the oxygen in. Some COVID patients have looser lungs. We don't have to use as much pressure. Every patient we treat individually. It's not an algorithm we follow and we follow it blindly, that we say this is a ARDS patients, adult respiratory distress syndrome, which is the end stage of most COVID disease. We don't treat them blindly. We have to make this machine, match it to the patient, and get the oxygenation we want.
Thank you very much, Dr. Parkinson, for that very informative and important information on ventilation. Members of the media, the floor is now open. Remember to identify yourself and the media house you represent before posing your question. We want to give as many of you an opportunity to pose questions to us, but that means in our limited time, we will have to give each media house a chance to get a maximum of 2 questions in. And once we have completed the pool and time allows, I will come back to you. Let us keep this in mind as we begin taking your questions. TV6.
Good morning, everyone.
Good morning.
Elizabeth Williams, TV6. I know at one point in time, Minister Dial Singh, he would have stated that additional ventilators would be coming for Tobago. I just wanted an update as to if these ventilators were sent to Tobago.
Sure.
And my second question, with respect to the government of New Zealand, they would have taken a 20% pay cut in light of COVID-19. I don't know if it would have come up in cabinet with respect to government ministers taking a pay cut and some of these monies being used to assist persons in need throughout the country. Because there's a situation here in Tobago where many people are saying that they are not getting their food cards. They are not getting any food supplies and many are in need. I know that the THA would have announced yesterday that they are giving out 100 hampers by next weekend, but that is still not enough. I don't know if you can look into that and if you could state whether in terms of a salary cut, if that was brought up in cabinet.
Okay, thank you for the questions. So on the issue of ventilators, there are 69 ventilators dedicated to the COVID response throughout Trinidad and Tobago. I don't think we have anybody on ventilators right now.
Not that
I don't think we even have anybody on ventilators right now. In Tobago, there are 5 ventilators dedicated to the COVID response. And yes, as soon as that shipment of 10 comes in, as I have already expressed, 4 goes straight to Tobago. As you know, international flights, and whenever I speak about this, I always say it depends on the flights. The ventilators are ready to be sent via air cargo. As soon as they come in, Tobago will get their extra 4 to bring them up to 9. On the issue of cabinet discussions, I am not allowed to speak about cabinet discussions. All cabinet discussions, for the sake of running the country, must remain confidential. On the issue of food cards, I will certainly bring that issue to the Honorable Minister of Social Development and Family Services, the Honorable Camille Robinson Regis. Thank you very much.
New source. Is New source on?
Yes, I'm on, but I didn't raise my hand to ask a question.
Oh, I saw your hand up. Okay, well,
No, I didn't. I didn't raise my hand to ask a question. I mean, I could make a comment and say to the panel, thank you very much for the demonstration, especially about the ventilators, and also thank you to Dr. Parastram for clearing up the whole issue about the testing. I look forward to seeing the video about the testing process.
Let me just make one comment about ventilation. You know, in some countries right now, they are using 1 ventilator to treat 2 patients because of lack of ventilation. And the point I want to make to Trinidad and Tobago, do not take where we are for granted. We have 67 ventilators, 69 dedicated to COVID. Some countries don't have ventilators. Some countries are treating 2 people on 1 ventilator. But if what is playing out in the national community as reflected by these headlines in the newspapers continue, I fear for what will happen to Trinidad and Tobago.
Thank you. Guardian Media Limited.
Good morning to the panel.
Good morning.
Minister, you've expressed concern that we've seen so many persons out in public now, perhaps a sense of complacency or otherwise, like you said, non-essential tasks being looked after. Barring moral suasion and getting the police out there in their numbers, is there anything else that the ministry or perhaps the Ministry of National Security can do at this point to make persons actually stay at home? And secondly, to the CMO, if you could just clarify for me the clinical update, you said that there were 60 persons hospitalized, with 10 at Cora and 59 at Covert, so the numbers aren't adding up there. So if you could just, perhaps I may have misinterpreted that as well. So if you could just clear that up for us, please.
Sure. So let me take the first part of your question. Annalisa, I fully agree with you in that there seems to be a sense of victory amongst the population. You call it complacency, I say a sense of victory. Two ways to see the same thing. Whilst I laud anybody's attempt to distribute food, laudable objective, I think the way it was done yesterday raises a clear and present danger to Trinidad and Tobago. I want to commend the police, and this is where I think strong policing is going to have the effect. I am sure that the public, via strong policing yesterday, will get the message that if you go out to sell a dog and meet your boyfriend, you will be inconvenienced. Those are not essential trips outside of your house. The Minister of National Security and myself, we monitor the situation literally on an hourly basis. And if we detect that something else has to be done, we will make the necessary recommendations. But we have won nothing. Let us continue with 4 simple words: save lives, stay home.
Okay, so let me just give you back the update in terms of hospitalized patients in case there was an error. So there's 60 patients hospitalized, as you said. There are 59 of them who are ambulatory across the system, 49 of which are in Covert and 10 of which are in Cora. So the total number of hospitalized patients remain at 60.
Thank you. 91.9.
Hi, good morning. Vern Extevor, 91.9 FM Street. And just 2 quick questions. Minister Dialson, if you could just take me back a little bit to the ERHA report that you would have requested.
Yes.
I know you did say it was forwarded to the legal team. I want to know if you could probably just identify any of your particular concerns that would have made it go to the legal team. And I'm also trying to figure out as well, looking at where we're at, and people are, as we say, getting complacent and celebrating victories of the plateau that we are experiencing. However, what can you advise the public in terms of our concerns that we need to look at in particular? And I'm talking here about community spread. Is it that people should realize that we still are at severe risk of community spread, and how high is that particular risk in terms of sending us back into a second wave or putting us into a place of of risk of contracting COVID across the country?
Sure. Thank you, Vern, for that question. Vern, before I answer your questions, I must congratulate you. 2 days ago, I think you did an interview with someone from Tobago who was quarantined. And that person said how positive the experience was, and that she was not able to take the virus home to her grandparents. Was that you on 91.1, I believe?
91.9?
Yes.
On 91.9, yes, that was me. Yeah.
And I wish that story will get wider circulation, because that speaks to the same issue you have read, community spread. That person in Tobago subjected herself to quarantine, and she spoke so positively and in a very mature manner, where she put aside her personal comfort for the security and health of her community. And that's how you stop community spread. And I wish that story will get wider circulation. The report. No, I had no particular concerns. It is simply the way these reports are dealt with. It goes to legal. So it has gone to legal, and then I will be advised by them. And on the issue of complacency and community spread, I will now like to ask the Chief Medical Officer to explain more about what community spread is and how we could prevent that.
So I would have said before that we were looking at a few possible cases of local spread. We are listed on WHO's website. If you actually go onto WHO's website, you will see Trinidad and Tobago listed as sporadic. Now, the categories that they have are no cases at all, sporadic, meaning that we have maybe 1 or 2 local cases, but the majority have been either linked to travel, directly as a result of travel, as a result of primary or secondary or tertiary contact. So that's where we are at in terms of our definition of spread in Trinidad and Tobago. Other countries in the Caribbean would have been listed into the cluster zone, where you have 1 case that they can define that has actually caused a cluster of cases around those cases. So their secondary, tertiary, quaternary contacts are now becoming positive around those cases in the same vicinity, usually geographically. Beyond that, it goes into widespread community spread. So we are at the sporadic phase. It can easily become cluster cases if one of the people that are supposed to be in quarantine, self-imposed or otherwise, go out into the community, go out into the gatherings that we saw yesterday going on throughout the country, and actually spread it to a number of people. One person can spread it to quite a large number of people in one setting, as we have seen in other countries, happening with church gatherings, happening with markets, within markets especially. You can see an explosion from one single individual. And that's why it's very important that we maintain the stay at home for as long as we possibly can, while the numbers are remaining flat. One case can cause an explosion and cause our numbers to go out of control. So that is the progression of spread that can occur.
CLC.
Good morning, Anil Siratan from Caribbean Lifestyle Communications.
Good morning.
Good morning. Morning.
I just want to, this is for the CMO, I just want to get some clarity on the community testing. How many tests are being done per day? And also, will the areas with the positive samples be published? Thank you.
Right. So that's a good question. So we have chosen one health facility within every county of Trinidad and Tobago. So 9 facilities. So they would be sampling one patient in the first instance per day per facility. So we're looking at 9 samples per day. In a full week, we're looking at anywhere between, I would say, 40 and 50 samples coming into CAFA's lab from the community sampling initiative. Once we get our lab up and running, we'll probably look at expanding, because CAFA has to do testing both at the community level as well as our routine sampling. So they have, of course, some constraints, but once we get our sampling up and running, we'll be able to expand our community initiative in a week or 2.
CNC3.
Hi, good morning to members of the panel. Jesse Ramnew from CNC3 News.
Morning, Jesse.
This question could perhaps be dealt with by the CMO. Dr. Parasram, we've gotten some reports that patients at the San Grande step-down facility, they're a bit concerned with the timeliness of testing being done on them. Some are questioning the criteria because they feel as though not enough is being done within the stipulated window, and that the future of their results sort of remain in limbo. I don't know if you could just break down what's the testing criteria for the patients at the San Grande facility for us. Okay, so as you know, and we have discussed before, we're looking our first test. So patients become positive. They usually, in the case of the San Grande individuals, they're in a step-down facility, meaning that they have no further symptoms. We have to wait 15 days from the onset of symptoms to the date that we take the first test to determine if you are having a negative, right? So 15 days goes by from the onset of symptoms to our first swab. Once we do our first swab, if that test is negative, we repeat the swab 24 hours later. If the second test is negative as well, you can be discharged. So you have met the laboratory discharge criteria. However, if the first or the second test is positive, we, according to CAFA's laboratory discharge, we have to wait a further 7 days before we can actually do another retest. If the other retest is negative, then we do another 24 hours, we get a second negative, then you can go home. However, unfortunately, if any of them come back positive again, we have a 7-day cycle that we have to wait upon before we can resample. And I know it's difficult for the patients to wait that length of time. That is CAFA's guideline as of now. And they have done so because worldwide we are seeing you may have a negative and then you're getting a positive days or even a week after. So they are being very rigid with the discharge criteria, and in this phase of the epidemic especially, where we have limited spread, is important that we stick by the discharge criteria, be very stringent with it, because we don't want persons going back too quickly into their homes with false results and then infecting their families and infecting the community, the wider community, based on a result. So we are sticking with the rigid standard that is laid down by CAFA, making sure we get our 2 negatives before we are discharging patients. Other countries have variations of the same, but we are following CAFA's guideline as for now.
ACP News.
Hi, good morning. Priya Bihari AZB News.
Good morning.
I just want to go back to the health centers. When someone gets tested, do they go back home? And is it one sample that would tell, that would be tested for COVID-19 for all of the other influencers, like H1N1, etc. And the other issue in terms of the press release, the CMO has promised to put the number of patients who have actually tested. When would we see that? And sometimes can we get how many patients have been tested negative for COVID-19? Those are basically my questions.
Right. So in terms of the sample that is taken, as I said, it was a nasopharyngeal swab that is taken at the health center. That swab is the same swab that we would have used for H1N1 in the past. What happens is if it is negative for COVID, we can ask them to do, that is CARFA that is, to do a 14-panel respiratory screen, which is inclusive of H1N1 and a number of other pathogens. So that is actually done across the board. In the early days of the epidemic, we would have done both samples, both COVID-19 and the respiratory screen for everyone that was sent. And it is the same test, it is the same universal transport media that we were using, so that the sample is the same. In terms of the second test, I confirm with CARFA that the numbers that we are giving you does not include tests that have been rejected by CARFA. So basically our number of tests submitted would be numbers of tests submitted and actually taken in by CARFA. I will have to get CARFA to give us an actual number of rejected samples, but let it be known that it will not get the number of samples submitted. Those numbers actually will be more akin to actual patients, minus of course the repeats that would have occurred, than if the rejected was part of that sample.
Just before we leave, I just want to make a plug that we have Dr. Anthony Parkinson here this morning, and I know at every press conference questions are always asked about ventilation. So I am hoping we could take advantage of the expertise of Dr. Parkinson this morning, because it's difficult to bring back the experts all the time. So please avail yourselves of the opportunity to question Dr. Parkinson.
98.1.
Good morning to the panel again. Stephen Cummings, 98.1 FM. Two questions, two quick questions. In presenting some statistics on the last occasion on Trinidad and Tobago's caseload per million, which the Minister of Health said at one time stood at 64 and then jumped to 81 per million population, representing a 26.5% increase. Are there any new revealing statistical figures that you can share on Trinidad and Tobago as of today? That's the first question. Second, I read where new approval is said to have been given for export to this country from India. A new batch of drugs, including hydrochloroquine or HCQ. Are you able, Minister of Health, to confirm or give a status update on this?
Sure. So at an earlier press conference, I did indicate that we had written to 3 embassies in Trinidad and Tobago to make sure that we have a supply of PPE, drugs, and so on. And those 3 countries were China, India, and I believe the United States. So both China and India have responded, and they are making every effort to release drugs. However, the drug hydrochloroquine is not to be used for COVID-positive patients. As we indicated since this crisis started, that we will not be using non-proven experimental treatments on our population. I am happy to say that since that time, an actual trial of hydrochloroquine in France actually showed that 11 people died because of hydrochloroquine. So I think we in Trinidad and Tobago, always led by the science, made a very, very important decision not to follow the trail of hydrochloroquine. India has lifted its trade embargo on the export of pharmaceuticals and non-pharmaceuticals, which is a very good thing because we need to have our pipelines open. On the issue of our caseload, I am checking it now for you. Trinidad and Tobago is now at 81 cases per million population. So we have more or less remained constant. When we started giving you these updates about 2 weeks ago, we were at 64 per million. So we have gone up by about 26%, but the world has gone up by 220%. So those are the metrics that we use. So I hope that answers your questions. Mr. Cummins.
Thank you, Minister. I recognize Newsday.
Hi, good morning, Jen Slovan, Newsday. I have a question to Dr. Parkinson.
Ah.
You all hear me, yes?
Yes, we're hearing.
Dr. Parkinson, I was speaking with a nurse yesterday in the US, and she was telling me one of the methods that they are using is proning patients rather than the ventilators. Could you give us some more information on proning patients and whether it's better than using the ventilators? And also, what are some of the dangers of using the ventilators and being removed? That's one question for Dr. Parkinson. And the other one to Dr. Parshram. Speaking of the tests that we're going to expand in the communities, one test per day, how are these people going to be selected? And also, when are we going to start, if at all, testing for antibodies?
Okay, Dr. Parshram will go first.
Yeah, so the selection of the cases are strictly based on what we're looking at from the physicians in those facilities. They have been guided by our National Epidemiology Unit as to how to select, and the physicians will be selecting not randomly, but based on case definitions and going outside of the normal case definition for COVID. So we're making sure one that is not within the normal case definition is actually outside of that. So it's just a random selection of people who don't meet the case definition, which in a normal instance would have been rejected by CAFA. But we actually had a discussion with CAFA to allow us to do those sorts of testing in advance, and they have agreed to do so. You asked a second question to me. Just you could repeat your second part of the question before we go on to Dr. Parkinson.
The antibodies, when are we going to start, if at all, testing for antibodies?
So we just completed discussions with the Pan American Health Organization, and we have seen worldwide that the antibodies tests that are available are not of a good standard at this point. So we will continue to look, as we always do, in terms of testing and expansion of testing. And they would have even drawn reference to a country that bought over 1 million of these antibody tests and had to actually discard all of them because they found out after they procured it that it was not useful at all. It was probably better to have a clinical guess than using it. And they would have bought more than 1 million. And this is from the Pan American Health Organization, and they actually had to discard all of them. So we are taking a very, very close look at it. We are being very cautious as to how and when to use it. But as of this point, we are sticking with the PCR test, which is the gold standard that is being done at CAFA.
Okay, Dr. Parkinson.
Okay, proning, that's a very good question, a very important question there. Proning is the act of, instead of the patient lying on his back, is to put him to lie on his stomach. Now what that does, it improves the ability of oxygen to reach deep into the lungs, and also improves the ability of the blood supply to take the oxygen away from the lungs into the bloodstream, etc. Now it works very well. We use it while a patient is on a ventilator. However, what is coming up now is that during the evolution of the disease in a patient who doesn't need a ventilator yet, they have shown that it actually does help by patients sleeping on their stomach. So if you're having difficulty breathing, even before you reach a ventilator and you have a little bit of oxygen, you turn on your stomach, and that seems to improve your oxygenation. However, that's not an answer. It's just a way to a maneuver to increase your oxygenation. However, that may, in many instances, evolve towards needing a ventilator. Now, as I mentioned before, a ventilator now tries to mimic the lung. It tries to push air into the lung. The object of the ventilator is to get oxygen right down to the what they call the little air sacs, like little balloons, small balloons at the end of the lung, fill them up with oxygen. There's another problem. These air sacs like to collapse. They collapse by themselves. The only way to keep them open in a sick COVID patient is to put a little bit of pressure in the airways, and that air pressure opens up those alveoli. And then the oxygen is able to reach it. So inevitably, you reach the stage of a ventilator. Some people, when you reach that stage, you are very, very, what shall I say, sick in the progress of the disease. You are very sick. Now, can a ventilator cause damage to the lung? Any procedure done in medicine has some side effects. A ventilator can cause some damage with respect to how the pressure opens the lungs and closes the lung down. That's volley trauma, barotrauma, to do with the volume and the pressure in the exit in the lungs. High oxygen concentrations. People think oxygen is wonderful for you. Breathe a lot of oxygen. It will be a high percentage oxygen. It should be good for your lungs. High percentage oxygen actually can damage the lungs. However, the ARDS protocol or the guidelines we have for treating ARDS actually speak to all the different complications that will occur in a ventilator. How to minimize the amount of oxygen, how to minimize the amount of pressure and the volume of the breaths we give to patients. Proning does help as well to improve the oxygenation up to a certain point. And these methods do reduce the complications. But no matter what we do, taking Panadol, for instance, it's safe. But up to a point, if you take too much, it can destroy your liver. And you may die as a result. I'm not saying stop taking Panadol, all right? Still take a Panadol, but don't overdo it. Ventilators, it will save a life. People are trying to say, let's avoid ventilation. Let's use the non-invasive ventilation. Use an oxygen mask or this special oxygen mask that actually has a bag that increases the amount of oxygen. But it only goes so far. And we have no choice but to put you on a ventilator. If we don't put a patient who needs the oxygen on a ventilator, the only thing that's going to happen to the patient is going to die sooner. If you put a patient on a ventilator, we're hoping to give them the best chance they can. Unfortunately, with this virus, a large percentage of patients who reach the ventilator stage, they do die. We have no magic bullet to treat the COVID-19. None whatsoever. The only weapon we have against it is separation. That's the only weapon we have against it. If that is not handled properly, you will end up with a lot of patients being on a ventilator. Don't reach a ventilator.
Thank you very much, Dr. Parkinson. But before I take another media house, I want to go back to a question asked by Elizabeth Williams of TV6. Liz, the MPs in Tobago both have said that have their quota of food cards for children on school feeding, and both have said there is no problem. The THA has also been doing their part with no hiccups. Actually, in Tobago this week, we had the return of 3 food cards to one of the MPs because the persons who had received also from THA. The Ministry of Social Welfare's office in Tobago is open, and people are receiving the same high level of service as they receive in Trinidad and have been applying for all of the grants that are being offered by the ministry. So I hope that clears up some of the misconceptions or misinformation. I move to Tobago, Channel 5.
Yes, good morning, everyone.
Good morning.
I can have you hold out Tobago Channel 5. My question is for Dr. Parasram. Dr. Parasram, I don't know if I missed it, but with the sentinel testing in Trinidad and the surveillance testing in Tobago, what it is that your office is hoping to achieve by kind of these tests? What is the picture you're trying to get?
Right. So whenever we do sentinel surveillance, and this is not something that is new to public health, is not new to COVID. So what we do is we do random sampling of the population with what we call acute viral illness, which is AVI. It's a surveillance category where people present with fevers. Some people have respiratory symptoms like sore throat, maybe stuffy nose, those kinds of things. And we actually sample the population to find out, one, what type of viruses are circulating at any given time. So we would have done it before in a larger amount when we had H1N1 to see what other types of viruses would have been circulating in the country beyond H1N1, and we are doing it again to basically see what else is circulating. Of course, it will also tell us if we have people outside of the case definition that we have been using coming back as positive for COVID. So that will be if we are seeing those kinds of things, it gives you some degree of evidence that there's a different type of spread that is occurring. So we're doing it for those two main reasons.
Okay, we move back to CNC3.
Dr. Parasram, this one is for you, but perhaps Minister Dialsingh can also chime in as well. With Government Assembly of a team comprising mainly of economists and businessmen to chart the way forward post-COVID-19. Now, we know the purpose is to maneuver the country's economic future, but based on from where you sit and your standpoint, do you think someone from the medical field should have also been included in the formation of the team, given that this team was born out of a pandemic and that person from the medical field could have provided some meaningful contribution in shaping some of the discussions?
Thank you very much. If I remember clearly, when the Honorable Prime Minister announced the team, he made it very clear that they are able and willing to co-opt any association or individual. And if the Ministry of Health and medical personnel are to be co-opted, we stand firm and ready to support the national effort.
If I may, as you are aware, we have an Inter-Ministerial Committee that keeps abreast of the public health information, and we have a reporting line to both the Minister of Health and the Minister of National Security, and that continues. We have a weekly meeting, and sometimes we have ad hoc meetings of different subcommittees. So we will continue to do that and supply Minister Dialsingh as well as the Minister of National Security with the reports and the minutes, and that could easily be filtered to that community, to that new committee as well.
91.9, you have another question?
Hi, good morning. Yes, hi, good morning. Just again, going across to Dr. Parkinson. Sometimes I feel we put the horse before the cart at times, and I wanted us to go back to the definition for COVID-19 and explain how that particular virus affects the human body. In particular, we've heard reports where one guy referred to it as turning his lungs into glass. Wanted you to explain to us how the virus operates in terms of creating mucus in the body and blocking the air passageways. And also, if you can, speak to our own local treatment of things by using things like Zeva Peak and orange peel and garlic and stuff like that, if those things do actually help or would help in the fight against COVID-19. Just in general, a clinical kind of definition of COVID-19 and whether our local remedies like Zeva Peak could work.
We'll take that.
Dr.
Parkinson.
Okay. First of all, the COVID virus, like many other viruses, when it attacks the body, it causes an inflammatory response. Now, this inflammatory response manifests itself in the lungs. This so-called ground glass appearance is not glass in the lung. It's how it looks on the CT scan, especially, as a kind of a hazy looking area on the CT scan. We in medicine love to use things like it's the size of a grapefruit, it looks like ground glass, it looks like an asparagus, whatever. We like to use these descriptions. It's probably not the best thing, but this is what we do. So it's not glass. However, it's an inflammatory reaction that fills up the little air sacs in the lungs with a fluid and eventually a membrane that stops the oxygen from getting past that membrane into the bloodstream itself. That is the basic thing that has happened with the COVID when it reached this stage. We were talking about the bad stage. Most people get this very slightly and then they recover. But it's actually your own body, it's the defenses your own body has that kind of works into overdrive that causes this kind of reaction to take place. Science doesn't understand it yet. We call it a cytokine storm. And with COVID, we get multiple cytokine storms. Treatment of that, as I said, we have no treatment, no cure. Until we get some sort of antibody or something, a vaccine, we have no cure. The only thing is keep people separated as much as they can. However, there are other things people try to do to improve your immune. All these other local compounds, etc., I have no scientific evidence to prove that it works. If you wish to use it, fine, as long as it doesn't interact with your medication. Some people suggest take vitamin D. It helps to increase your innate, what shall I say, defense mechanism, immunostrength. It seems to do that, but there is no scientifically proved at this point in time, drugs, vitamin, keep whatever you want to call it, nothing seems to be able so far to stand against this virus.
Thank you very much, Dr. Parkinson. Before I move on, Minister Dialsingh, there's a question here for you. Minister Dialsingh promised access to the media to some of the quarantine patients who want to share their experience. When will this happen? And the fact that the number of positive cases has not moved in over 2 days, could this be an indication of mild cases failing to present themselves for testing?
So I will take the first part and the Chief Medical Officer will take the second part. So I did promise last week Saturday that the patients at Sangre Grande wanted to tell their side of the story. Saturday night, that was carried on one of the local TV stations. And Sunday, Easter Sunday, there was an article by, I think, Ricky Ramdas giving their side of the story. Further access to the media is up to the discretion of the patients. We did fulfill our initial promise, and they have told their sides. Doctor.
Yeah. So in terms of the mild cases, as I said before, there's a possibility that people would have be almost asymptomatic, meaning they may have 1 day of sore throat, they may have 1 day of even fever, and then they go back to a completely normal state. Those persons generally don't present to a healthcare facility for any disease. They stay at home, they take their medication, they feel better, they move on. The patients that we see presenting generally are people that would be moderate to severe, with diseases that last a few days, and of course with those that present with shortness of breath and severe signs of illnesses, those will definitely present to us. So in any surveillance system, the surveillance system generally is built to pick up cases that present to the healthcare facilities. What we were hoping to do is actually set up the drive-through settings where people can actually feel a little more comfortable to those with milder symptoms to come out. You drive through, you have your test done, and you return home, and then we can have persons with mild symptoms possibly presenting, or someone that thinks that they're just suspect, but bearing in mind, of course, they have to meet the case definition as well. So there's some pre-screening that has to be done. So in any epidemic, we tend to pick up moderate to severe disease based on the concern of the population. In the early days, something new, you tend to see an influx of people with mild disease as well, presenting to the facilities to be tested because of the concern of death and significant morbidity. So as complacency sets in, you tend to find people with milder disease don't present to tests. But the concern is if you have a condition that starts off as severe, develops quickly at home into shortness of breath, especially with people that have diabetes, comorbid conditions, diabetes, hypertension, and the like. We want you all to present to us so we will know what we're dealing with at an early stage. The earlier you present, the better our chance is for persons like Dr. Parkinson to have a good chance of keeping you alive once you get into the facilities. So we are urging people to come out, even if you have mild to moderate symptoms. Use the hotlines that are available to call in, and they will basically do phone surveillance to tell you if you're at risk. Make sure you present either virtually or otherwise to our facilities so that we are able to tell if you are a candidate for COVID-19.
Thank you very much. Elizabeth Williams.
Good morning again, Elizabeth Williams.
Good morning.
I know, Minister Cox, you would have said about the food card situation. I don't know how much, in terms of those some food cards being given away. I mean, you said that those food cards were returned. There are a number of people in Tobago, East and West, who keep contacting the newsroom with respect to that they don't have any food. So I'm not sure what the situation is. I will try also to reach out to the MPs, and they can also link with the media houses in Tobago to know, because I have like a list, several pages of people who are in need at this time. But my two questions, one for the CMO and one for Dr. Parkinson. This one is for Dr. Parkinson. If we hypothesize reaching a situation of ventilation usage, how are these tubes cleaned, sanitized for use by another patient? And is there a specific time frame to swap between patients? And the other question for the CMO, when stay-at-home measures are lifted, how long do you suggest that we still wear masks in public? Thank you.
Okay, before they answer the question, the members of Parliament, Tobago East and Tobago West, their story is very different to what you are alluding to at this time. So we will get back to you on that, and they will be checking on it too. Okay? Dr. Parasar?
So in terms of the mask, as you have noted, it is one part of the public health armory. It goes along, it provides some degree of protection, but it also goes along with social distancing, with hand washing, with cough etiquette, with sanitization. So it is all part of one package. Only time will tell in terms of how the epidemic progresses as to how and when the world will go back to its previous state. I don't think that there would be a state anytime within the next few years that we can actually revert to the way we were prior to that in terms of public health measures. People will continue the social distancing, they will continue the hand washing, I hope, for a long time to come. And therefore, not only with COVID-19, but we will see a lot of improvement in the way infectious diseases like gastroenteritis, like H1N1, we would see reductions in those numbers in the coming months or years if we continue to practice these measures for as long as we possibly can. As I said, mask is only one measure of the lot, and I can't see us going backwards in that decision for quite a little while to come.
Okay, we are literally out of time, and I would like to ask the Minister of Health to give us his closing statement.
Thank you very much, Minister Cox. I want to thank the Chief Medical Officer for lending his expertise as the senior public officer in this endeavor. I would also like to thank Dr. Anthony Parkinson, who voluntarily came here to share his medical and clinical expertise. Ladies and gentlemen, it is good to reiterate the following point. The world has changed more in the past 4 months than possibly the past 400 years. We have to adapt to the virus. The virus isn't going to adapt to us. Change is mandatory. Our change behaviors are mandatory. They are not discretionary. They are not optional. Elizabeth Williams asked about masks. It is very possible that the wearing of masks, as the Chief Medical Officer has said, may be a permanent fixture for the next few years. Handshaking is going to be a thing of the past. Hugging and kissing in social settings will be a thing of the past. How we dine out is going to be a thing of the past. Massive sporting events where you have 100,000 persons looking at football is maybe a thing of the past. The point is, our survival as a society now depends on our ability to change. And change we must. Because if we don't, we will fail. And failure at this point is not an option. Please, the Honorable Prime Minister has expressed his strategic objective in 2 simple words: save lives. And the only way we can save lives is to stay home. I am hoping that those 4 simple words, save lives, stay home, will redound to the benefit of all of us, and may God continue to bless Trinidad and Tobago.
Thank you very much, Minister. I just remembered that there was another part to the question from Elizabeth Williams concerning the ventilators to Dr. Parkinson. Could he answer now?
Yeah, sure. In a nutshell, everything that reaches the patient from the ventilator is disposable. From the endotracheal tube that we put into the lungs to the tubes that come to the ventilator. They are all disposable. We never share them between patients. Secondly, we will test patients for bacterial infections at certain intervals. But we would not be testing for the COVID virus until when the patient recovers. I think that answers the question.
Thank you very much. And we have come to the end of today's virtual media conference. Do remember that the Ministry of Health and the Ministry of Communications are your only credible sources of government information on COVID-19. And today, as we leave, remember to continue to be empathetic to all those who are affected and their families. as we all cope with COVID-19. We want to remind you that NIPDEP, on behalf of the Ministry of Finance, is inviting tenders to manufacture cloth masks. The government is targeting interested individuals, sole traders, and firms. Please check the daily newspapers and www.nipdec.com for further information. The deadline for the submission of proposals is Friday, April 24th at 12 noon. These masks will be distributed free of charge to the public. Members of the media, we want to let you know that our next media briefing will be held on Monday. The Ministry of Health will provide an update tomorrow evening. I am Donna Cox, Minister of Communications. Thank you for joining us today as the government continues its efforts to flatten the curve and beat COVID-19. Stay home, stay safe. May God bless Trinidad and Tobago.
And that was a Ministry of Health update on the COVID-19 pandemic here in Trinidad and Tobago. And just a quick review of some of those points that we just heard. We heard the Minister of Health, Terence Dialsing, expressing concern that some sectors of society are still not getting the message to stay home and to stay safe. He congratulated the Commissioner of Police, Gary Griffith, for coming out yesterday, for bringing his officers out yesterday for the day of policing to reinforce that. And he also said he made an appeal for all citizens, regardless of political affiliation or socio-economic standing, to stay home. We heard from Dr. Anthony Parkinson, a technical advisor in the Office of the Chief Medical Officer, and he there gave a demonstration of the ventilator with regards to the treatment of COVID-19 patients. And of course, he stressed that there is no magic cure for COVID-19. He said separation is key, that is social distancing, to stop the spread. And the Chief Medical Officer, Dr. Roshan Parasram, gave us a clinical update. Right now, the number of confirmed positive cases remain at 114, and there have so far been 21 persons discharged from hospital. The last person was discharged yesterday from Cora. Well, that's a quick snapshot of that press conference that you just heard. And of course, we are being reminded that we must stay at home to stay safe and save lives. I'm Stacey Ann Providence. Stay with us here on TTT Talk City 91.1 FM, Suite 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online for the latest COVID news. Bye for now.
My name is Wendell Lightning. I'm the Public Relations Officer for NLCD Frontcare. On behalf of our sponsors, Board of Directors, management, stateside players, and Panama players, let me say a heartfelt thank you to all the